Welcome. I must say, it is so good to see all of you here. And those who don't know me, my name is Dr Lele Rangaka, and I'm the director of this new fabulous WHO Collaborating Center on TB Research and Innovation. And it feels really good to say that. It's an incredible achievement, so well done, UCL. So the launch of this new CC is not only a celebration of the journey that it took us to get here, but also we get to celebrate the shared vision that we have to transform research for greater impact. For me, that journey starts in 2018. And I was reminiscing with Alberto just before the event about the WHO days, and I realized that, yeah, that's where the story needs to begin. So many of you will remember 2018 was a very big year for tuberculosis. We had the first ever UN high-level meeting on tuberculosis that year, where member states got to pledge really big commitments for ending TB. And one of those commitments was for TB prevention. 30 million people were to be put on TB preventive treatment between the years 2018 and 2022. So it was an incredible thing for the TB community as a whole. And I particularly enjoyed that moment because at the time, I was a consultant at the WHO Global TB Program within the unit that is responsible for normative guidance on TB prevention. So yeah, I had the first row seat to one of the biggest moments on TB history. But I found the experience of the WHO not only inspiring, but humbling as well. Inspiring because I got to witness the collective drive, the specific activities that go into developing guidelines. And I also got to appreciate the role of stakeholders and academia being a part of it. I'm a bit biased here, but I think academia is the backbone of policy development. I found it a little humbling because I realized a simple truth for myself, though. That is, the pat on the back that I give myself for generating 1 or 2 evidence points that end up in guidelines, it's not going to be enough. It's not going to be enough to ensure that we scale up our interventions successfully and we implement them. So we need to do a bit more. Because if we don't get implementation right, we're unlikely to realize some of the big impacts that we want to see, which is reduced death, reduced disease overall, leading to significant social impact. But there's a catch, I realize. Implementation is not the end process. It begins with high-quality research, where we had to understand what people want and bring them along with it. Now, leading UCL's bid towards designation, for me, signifies my commitment to bring people along. And as a center, this designation means that we're committed to doing high-quality, policy-informing research that informs implementation and that we get to innovate to make sure that process happens. Now, today is June 16th. In South Africa, I'm South African born. In South Africa, it's a big day where we get to commemorate one of the really awful days in our history. So I thought it'd be good to quote Nelson Mandela. And he said, "It always seems impossible until it is done." So for us, it did take a long time, about 3 years. It was long, but we got it done. So thank you. So we have a full program today, and we will hear from friends and strategic partners who will also share what designation means for them. But first, we're going to get words of welcome from, first, the Regional Director of WHO Europe, who's Hans Kluge, and then it will be followed by the Vice-Provost for Research, Innovation, and Global Engagement. Welcome, Professor Geraint Rees.
Professor Abubakar, Professor Jaffar, Dr Rangaka, past and future colleagues and friends, we live in exciting yet challenging times in terms of our fight against tuberculosis. We have an incredible arsenal at hand based on constant innovation, including top-notch diagnostics and medicines, reducing the length of treatment and increasing the chances of full recovery. At the same time, we are witnessing a serious setback. COVID-19 disrupted TB services and reduced TB notifications and numbers of those being treated. We also need to face the fact that the war in Ukraine, with significant internal displacement and a massive refugee crisis, may seriously impact the region's recent progress in fighting TB. That is why countries in our region have reinforced their efforts based on a new TB action plan for the entire region 2023 to 2030. We now need to work twice as hard, use the tools at hand and at scale, and we need to act now to ensure everyone has access to these tools, which brings me to this very moment. Today's launch of the University College London Institute for Global Health as a WHO collaborating centre on TB research and innovations is a recognition of its impressive work. Bravo! It's an opportunity to make use of UCL's knowledge and experience to support countries, shape policy, develop a workforce, and do research in the WHO European region, consisting of 53 member states across Europe and Central Asia. We at WHO Europe are thrilled to partner with UCL, a world-leading center of research and actions in global health, which I personally know very well. The TB Research Network and UCL has been actively involved in generating evidence and supporting the development of a WHO policy. But this is just the beginning, my friends. Changing behaviors and ideas, changing ways of doing takes time. For that very reason, we need smart ways to introduce and scale up innovation. One such smart approach is operational research close to programmatic implementation. An approach that allows building confidence in a tool while at the same time gathering local evidence. In other words, an approach that harnesses the strengths, expertise and networks of WHO and UCL. For the many professionals working on fighting TB, and more importantly, for the many whose lives are impacted by the disease, today's partnership could truly prove a game changer. Thank you for this collaboration, and congratulations to all of us towards a bright future free of TB.
I'm here as the Vice-Provost for Research, Innovation and Global Engagement to offer my congratulations. This is a fabulous achievement. You've already heard that. I'm sure you'll hear that many more times today. But I want to emphasise just what a fantastic opportunity it is, not just for UCL, but for all the populations and people affected by TB around the world. So thank you for all your efforts and thank you for your leadership in that. That's probably the most important thing I have to say. Now, what else am I going to say? I'm going to talk a little bit about impact. A modern university like UCL is something that really has a purpose that perhaps has been unchanged, I think, since universities were invented back in the Middle Ages. It's the intention to have a positive impact on the world. And we do that through education, research, and innovation. And then we create those changes for individuals and populations around the world through all the types of intervention that you're familiar about, from policy to new medicines to new approaches. When we quantify that for UCL, just as one university, we can ask economists to add up the figures and what's it equivalent in economic and social impact. The answer for UCL is £9.9 billion a year, which, to put it in context, is the entire economic impact of the London 2012 Olympics, but for UCL every year. That's the kind of impact that an organisation like UCL can have. So imagine what the power is if UCL can collaborate with institutions around the world and with other types of institutions that have other types of impact. But I want to draw attention to the fact that just putting it in numbers doesn't really elucidate all the hundreds and thousands of stories of individuals and communities that feel the benefit of that economic and social impact. It's those human stories, or those stories about the planet or the biosphere, that are the really important way we do it. We don't do it to make a figure of 9.9 billion, though we're incredibly proud of it. We do it because of the impact it has on individuals, communities, and the planet. So those individual stories and that responsible impact is one of the reasons why this centre is so important. Because, as you know, it's the first WHO collaborating centre on TB in the UK, and it's one of 28 globally. That's an amazing achievement. You want a round of applause there? I think we want a round of applause. And that's important symbolically for us in the university as a whole, not just for you as practitioners and people interested in policy and researchers and colleagues. It's symbolic for the university of our commitment to having a positive impact on the world, and it's symbolic of our commitment to engage across the globe. I think it's also important to say this isn't the only WHO collaborating centre we have at UCL, and so there are three others. You're now one of four. So there's the Collaborating Centre for Arts and Health that our colleague Daisy Fancourt leads, the Collaborating Centre for Oral Health Inequalities and Public Health that Richard Watt leads, and the Collaborating Centre for Research on Assistive Technology that Catherine Holloway leads in the Global Disability Innovation Hub. They are things we are equally proud of, and you now join that exclusive club at UCL. I would observe that many of those centres have huge impacts, both as collaborating centres, but also more broadly. So, for example, some of you will have seen the news yesterday that the Global Disability Innovation Hub has received a further £31 million investment from the government. Testimony not just to Catherine's leadership, but to all of the colleagues who work in that Global Disability Innovation Hub and the Collaborating Centre for Research on Assistive Technology. Now, I mustn't get in your way anymore. I just want to end by again saying, have a fabulous day. This is an amazing achievement. I'm proud to be here congratulating you on behalf of UCL, and I look forward and I'm very excited to see just what happens next. Thank you.
Thank you so much indeed, Professor Rees.
You're welcome.
And we'll move on online, asking Stela to come to the stage and make a presentation on behalf of the Regional Office for Europe of the World Health Organization. And Stela, please take the stage. Over.
Okay, excellent. First of all, I'd like to greet the whole UCL senior leadership that has joined today, and distinguished guests, Professor Abubakar, Professor Rees, Lipman, Hopkins, Dr. Rangaka, but also our colleagues from the WHO, Professor Alberto Matteelli and Dr. Tereza Kasaeva. It is a wonderful occasion to speak today on behalf of WHO Regional's Office, and our director passes her regards with Dr. Nino Berzulli. And it is indeed a wonderful occasion of celebrating the UCL's recognitions and its designation as a WHO collaborating center. We're looking forward in this new beginning together. This is also an opportunity to put back the spotlight on our unfinished business, the long-running epidemics that continue to threaten health and well-being in our region, namely tuberculosis, HIV, viral hepatitis, and sexually transmitted infections. These are not diseases of past. In many ways, they are also diseases of future. And the moment we lose focus, we are being reminded of their importance. My presentation today will provide a brief overview of the current situation and highlight the efforts of our GID team in changing gears in this marathon towards ending these diseases in 2030. So where we are in the region, so we have approximately 14 million people infected with B, viral hepatitis B, and 13 million with chronically infected with hepatitis C, and about 19,000 people infected with HBV and 300,000 with HCV, which also causes premature mortality. We have started a promising path towards hepatitis elimination, and we have potential successes in our region. There's progress in immunization, in the prevention of mother-to-child transmission, in blood safety. However, progress in testing and treatment cascade is much more modest than the targets. It is estimated that in 2019, only 19% of people living with HBV and 24% of people living with HCV were aware of the infection. And only 8% were treated for HCV. For HIV, some 2.6 million people live in our region of WHO European region of 53 member states. Unfortunately, we have missed the HIV targets, and we are unlikely to reach the 2025 and 2030 targets if we do not change the way we respond to the epidemic. The annual number of new infections and deaths increased in the past decade, and the cause is largely in the fact that the HIV response has become a subject of politics and division over societal values and attitude towards sexuality and drug use, not allowing to do effective prevention across the region. There's also over 50% of people living with HIV detecting late, and this has not changed over a decade. And this is the largest gap in cascade in diagnosis and treatment linkages to treatment. And I also put a small graph on a figure on malaria, because this is also with our team. We are much closer in reaching the regional elimination, with the last two countries seeking validation of elimination. However, with climate change and cost of importation, vigilance remains important. So moving to the next one, closer to the topic of today. So in terms of tuberculosis, TB, especially drug-resistant TB, and TB-HIV co-infection continue to pose major public health burdens in the WHO European region. The proportion of cases detected among new and previously treated TB cases significantly exceed the global average, and the treatment success rate have remained stable at 56 and well below targets of 75. However, the transition to all oral regimens and the observed progress of treatment success rates in XDR brings hope that improving the success may be within our reach. The TB-HIV co-infection is on the rise, and we reached 12% in 2020. As to TB preventive treatment, especially the focus of today, the progress, and Dr. Rangaka has mentioned the promise of 2018. In 2020, we fell short of the 2 million people to be receiving the TB preventive treatment, reaching only 16%. So moving now to the fact that we are faced with new challenges and multiple intersecting crises. When we are busy with other crises, other communicable diseases do not disappear, and this is exactly the reflection of that. The increasing gap between the number of people falling ill with TB and the number of people diagnosed and reported has actually increased in the region, and actually we are not recovering at the same pace as the rest of the globe. At the same time, we are living in exciting times for the TB. New technologies such as new diagnostics, fully oral medicines, digital health solutions, and innovative service delivery approaches are reshaping the response. So it is within this context that last year, the regional action plans for viral hepatitis, ending AIDS, viral hepatitis STIs for 2022-2030, and the regional action plan for TB have been endorsed at the regional committee in Tel Aviv. And it has been endorsed to calling for a renewed vision, revitalized commitment, and increased agility and a more fit for purpose response. So with very ambitious targets, as you can see here, some of them basically reducing the TB deaths from 26% reached in 20 to 75% compared to 2015 by 25 and 90% by 2030, reducing TB incidence to 80% by 2030 compared to 2015. So if we are looking at these ambitious targets, and knowing how the trajectory until now, can we think that it can be done? And we strongly believe in our team that it can. In fact, when developing the regional action plan, we have conducted an epidemic modeling exercise, and this gives us strong ground to support this cause. The rapid uptake of innovations, including an expected vaccine, will cardinally change the landscape and chances to end the epidemic, but it is still hoped by the end of the decade to get there. If we use fully the package of new tools, sequentially putting into place, it is possible to regain the path of incidence reductions towards elimination. If we scale up tuberculosis preventive treatment, the incidence target could be reached by 2034. And of course, with vaccine, if it happens in 27, we can reach the incidence target by 2029. So, but for this, obviously, we need some strategic shifts and operational shifts of the in the region. So we first is to renew the commitment and bring back the TB to spotlight. And the priorities are to set ambitious policies, fully fund the resource the TB plans, and improve accountability and multi-sectoral coordination. Second is to align with the European program of work and the universal health coverage and primary health care agendas by putting people at the center and leaving no one behind, with priorities to ensure complete transition to people-centered services, expanding delivery in primary and community settings through essential clinical and supportive service packages, prioritizing key and vulnerable populations and promoting rights-based TB response and equity in access to quality prevention, diagnosis, and care, and engaging civil society organizations and affected communities in the TB response. Third is to recalibrate the core TB functions by reducing incidence, finding early, and treating fully. Fourth is to take advantage of technological advances, innovations, and promising pipelines by accelerating deployment and use of new screening and diagnosis tools and medicines, vaccines, service innovations, and digital health solutions, and improving the data systems. And finally, overcoming the impact of the emergencies and crisis, the immediate priority being to regain losses due to multiple crises, ensuring universal access to TB preventive treatment, rapid diagnosis, and treatment of internally displaced people and refugees and migrants, anticipate the resources needed to support the TB response in member states, getting back on track, mainstreaming the TB response innovations, and planning for TB contingency and the resilience to future crises. So how we're going to do that? With a better balance of support at the regional, sub-regional, and country level. And so this can be done by putting in place effective actions and maintaining technical areas while putting the focus on accelerators. So my final few key messages are the following. We need to be ambitious in our implementation plans, and in turning the tables, we need to move the agenda forward, and we need to do more and different than we did before. We also need will, funds, people, innovations in our approaches. Innovation is actually key. We need to improve access and ensure all service delivery platforms are engaged, including community-based services, including primary care, and not in silos, using shared approaches where they make sense, and keeping the focus on core disease functions. Financial resources matter if we are to succeed, and we need both in financial and human resources. And the partnership with academia is one of the best ways to build capacity. But what ultimately matters the most is our mindset, perseverance, will, and leadership to eliminate the communicable diseases for once and for all. Thank you so much for your attention, and I look forward to this exciting event and to our steps together in the next years to come.
Stela. Stela, thank you very much indeed. So since the Collaborative Center have a coverage of the entire world, not only for the European region, and due to the fact that we cannot end tuberculosis in Europe without ending tuberculosis globally, I'm kindly inviting Tereza Kasaeva, the director of the Global TB program from WHO Geneva, to present her welcome and highlight the importance of the impact that you will bring in the role of the Collaborative Center to the global agenda. Over to you, Tereza.
Thank you very much, Andrei, honorable colleagues, dear friends. It's my turn now to join this excellent lineup of speakers and to share my words of appreciations and congratulations with the opening of new collaborating center at the University College London. Indeed, it's a very important step, very important day, and we are all excited about it. And I would like also especially recognize and share my greetings on behalf of myself and Global Tuberculosis Program to the colleagues with whom we are working already for many years. Now we are moving to a new stage, more formalized. A very warm greetings to you, to Professor Ibrahim Abubakar, and our former staff chair. We are in touch. We are working since 2018 together, and I think that this collaboration, fruitful collaboration, will be continued. A few additions on top of what Dr. Hans Kluge mentioned, Stella and other colleagues. By the way, some updates. I've checked before joining this call, so some information about our collaborating centers. And Professor Rees highlighted that we have 28, but apparently this is 30th collaborating center on TB. So, and we've reached this number, 30 collaborating centers. As you know, we have 30 hydrogen countries. And I'm now thinking what will happen if each collaborating center will adopt at least one hydrogen country. So it could be a new way of collaborating and addressing problems in hydrogen countries. But let's talk about it later. Few more numbers. Of course, fully agree with Dr. Hans Kluge. We are off track towards our ambitious targets. But it's also very dynamic time of opportunities, and we should look at the more opportunities given by accelerated research and innovations, and it's clearly seen in the frequency of update of WHO guidelines, in the introduction of new tools. Over the past few years, WHO recommended more than 12 diagnostics for TB. We've updated all our core guidelines on diagnosis, treatment, prevention, and screening of tuberculosis, and we have much better options. But now, what is the problem? That uptake is not fast enough. We need all hands on deck, and here I think collaborative centers are extremely important, playing important role. But we should rethink a little bit and renew our approaches, traditional approaches. I think that University College of London becoming collaborative center have very good chances to become pathfinder and best in the class and show how we can improve and contribute more actively and support countries in overcoming current crisis and addressing our problems reaching the targets. Lele mentioned about remarkable dates in 2018 with the first high-level meeting. Now we are moving towards second high-level meeting, which will be in September this year. Right now, the negotiations of the political declarations are ongoing, and of course, it's too early to highlight what how the political declaration will look like. But we see already strong support to the really bold actions, increased investments, clear and ambitious targets, and double, triple efforts to accelerate progress. We are not stepping down of our targets and previous commitments, but we are ready to accelerate during efforts. And I'm happy also that Lele mentioned the importance of prevention, TB prevention, and prevention as a topic to address every communicable disease. Unfortunately, for many years, this area was a little bit neglected, but the situation dramatically changed over the past years. And the reasons are absolutely clear: lack of resources, lack of research proving the importance and impact of the TB prevention, TB preventive treatment. Things are changing. And again, we believe that with support of colleagues of the University College, we can better address and promote. Targets were not reached. 30 million people were not provided by TB preventive treatment as it was requested in the political declaration. But still, the progress was also impressive. At least 15 million people were provided by TB preventive treatment. And on top of the targets, to the data shared by Stela, I would like to highlight that more than a quarter of the world population have been infected with tuberculosis. And in the current situation, with increased vulnerability due to socioeconomic impact, COVID-19 impact, climate changes, armed conflicts, so vulnerability of populations is increasing. And we should be very cautious. We should be prepared to address, protect, and prevent development of tuberculosis. Unfortunately, we see increasing incidence for the first time over the past 20 years. We see increase in mortality due to this severe disruption during COVID-19, and not only due to a lack of really comprehensive approach to address this complex problem. We believe that our collaboration and EU will bring a difference. We believe that we can develop new innovative models, showcase to other collaborating centers. And as our Director General, Dr. Tedros, is highlighting, we are looking for the investments. We are looking for the better new tools, of course, point of care tests, vaccines, effective vaccines, but sometimes we are not utilizing properly our closest and nearest opportunities. And I think that in general, our collaboration with, sorry for repeating, with the collaborating centers is one of the unutilized resources properly. Let's showcase, let's make the difference, and let's move together towards our ambitious targets. Thank you very much, colleagues, and congratulations once again.
We have a full program, so we just need to press on with it. Next is Marc Lipman, and Marc is the director for UCL-TB and TB Research Network at UCL. And we'll be talking about what we do here. Marc, please.
Thanks very much, everybody. And friends and colleagues, it's really great to be standing here representing the TB community. That's both researchers, clinicians, and I really love the word collaboration. Those of you who know me will know that's all I do. I like talk and I collaborate. That's what I do. And I always get a round of applause for it too. And thank you. And that word collaboration, I love the idea of that we're a collaborating centre. That's really important to me. The other thing that's key is partnerships, and I'm going to talk about that over the next couple of minutes. We are a very broad research network within UCL and also across a lot of the groups with whom we collaborate. I want to highlight some of those things. One point that was just pointed out to me by Ibrahim is the word education is not in our mission. It is, we've just forgotten about it because we do it all the time without considering it. So education is actually fundamental to so much of what we do. This is one of those confusing pictures of UCL. It's a very, very large institution. Within that, UCL-TB, that's what we do. We cover so many different areas within the faculties, departments, and associated partners. What's important to note is hats off to the Institute for Global Health. Shabbar, thank you for taking us on. It's super appreciated. And having a home within that of the WHOCC is really, really special. So what do we do in terms of the work that we do currently? Lele will talk later about the integration with the WHO Collaborating Centre, so I won't really focus on that. But I think you could break it into these elements. I just want to point out TB community engagement. I mentioned collaboration. Each year we do, and I'm very proud to say this, we run together with the London School of Hygiene, and we've got people from LSHTM with us here today, I think the best and the biggest World TB Day event in Western Europe. I could be very smug and say the world. I'm not sure about that, but it's definitely Western Europe. Another thing we're doing, and this is a shameless plug for an activity on the 30th of June, in partnership with the Africa Health Research Institute, we're running a program on bedaquiline and the implications going forward for what is a wonderful drug that may soon become a problem. So you're all invited, please sign up. I think these things are really, really important. Another key thing, which again Lele will cover, is where all this research feeds into in terms of impact and policy. Because at the end of the day, that's what we must do, make sure that our work is of relevance and of use and value. So locations, over 50 countries in the world is where our researchers and clinicians are based, and sort of some examples of the sorts of things that we do. Clearly, I'm not going to do anything more than just list the range of work. Just to point out, though, some of the key things. We work both in the global south and global north. We work in high and low TB incidence areas. We also work in people living with HIV infected populations and those where HIV is much less of an issue. That gives us a remarkable privilege because it means that we are constantly trying to listen to the people we're working with and adjust and build in work so that it becomes of immediate value. I want to just highlight a few of the studies that we're doing. One of them is Unite for TB. Again, this is way more than just UCL, but we're lucky enough to be the sponsors involved in both trial design and also the microbiology and a lot of aspects of Unite for TB. It is a very, very large platform, phase 2 study, which is looking to develop both new strategies and new drugs for tuberculosis. This sort of work is, I think, the only way that we can go forward. That's really important. One of the other things I said is that we work across lots of different groups. The other thing is adults and children. And I want to just focus on some studies that are being done in children because they can tend to be ignored a bit in TB. It all goes up towards MDR-TB and it's all assumed it's in adults. But actually there's some incredible studies that have come out of the MRC-CTU and the Centre for Clinical Microbiology focusing on firstly the SURE study, which is ongoing at the moment, which is a study in TB meningitis in children looking at the impact of drug therapies and also drug adjunctive therapies to try and reduce long-term morbidity and mortality. SHINE, which I'm sure most of you will know about, which is fantastic because it's been adopted within WHO guidance that a treatment shortening regimen can be safely and effectively used, and it's the same drugs just for less time. So that means less cost in every single way, and it's effective in non-severe child and adolescent TB. And finally, the CHAMP study, which is prevention of drug-resistant tuberculosis in children and adolescents. And my last pictorial image, which I think we're particularly proud of, is Periscope TB, which I use on a daily basis in my clinic, which is where we look on an individual patient basis at the risk of someone developing TB. What I particularly like about this is the graphics that are associated with it. I'm not going to take you through them now, but it means you can give a patient in clinic an idea of what is their visual risk. 10 in 100s, 10 dots compared to 90 that aren't illuminated, saying that is your risk over 2 years. If you do not have treatment, and if you choose to take treatment, it reduces to this. These sort of things are incredibly, incredibly useful, and I really look forward to promoting this and working, as I say, with everybody in this room and everybody elsewhere. So thank you so much for listening to me. Thank you.
Passing on the mic. Next is Professor Shabbar Jaffar, who's the Director of the Institute for Global Health.
Well, thank you very much. It's really nice to welcome you all here, really nice to see you here. So I'm the Director of the Institute for Global Health. We're one of, I think, 82 institutions within UCL. Our primary mission, the Institute, is actually to generate evidence that informs policy. We're into looking at big diseases, big systems issues, and the thing that binds us together is impact. And doing research that impacts policy, that impacts practice, and that changes people's lives. And that concept of impact, of doing research that's going to inform impact, it actually runs through from our early career researchers all the way to our senior researchers. Now, I've learned over time, actually, impact is only achievable when researchers and policymakers work together. They work together in setting the questions, they work together in coming up with the study designs, they work together on the statistics, they work together on the interpretation. That is absolutely critical, and they coordinate together. And I think that's what this WHO Coordinating Center, that's the opportunity it gives you. It will transform the TB research landscape. Within the Institute, within the Global Health Institute, we work on populations in the Global South as well as the Global North, and that's one of our strengths, that we have that breadth and we have that coverage. We have a critical mass which covers both methods, so strength in statistics. We have a very large health economics group in social science, and in modeling. So we have the method strength, we have the strength in the diseases, for example, in HIV, a long history of work in HIV and sexual health, increasingly in diabetes and cardiovascular disease, and we have a strength in health systems research. So those are the strengths that we can bring to bear and afford to the coordinating center. I think the other thing that I like to think that we're good at and that we take pride on is actually conducting research in partnerships, in equitable partnerships with policymakers, with actually patient groups, with civil society, with our partners in the South if we're working from the North. And that runs through every stage of our thinking. Last year or a year or so ago, one of our groups won the Times Higher Education International Partnership of the Year for building an equitable partnership that led to a step change in research. So, you know, I'm really pleased to be to see this coordinating center within the Institute. I think you have an opportunity to transform the TB research landscape. And, you know, within the Institute, we have a lot of expertise that will complement the work that you'll be doing. Thank you very much.
Thank you very much indeed, Professor Jaffar. And while we are meeting here face-to-face and offline, we have plenty of attendees that are with us and celebrating together with us this commemorable moment online. So we have plenty of the other collaborative centers that has been mentioned here already attending the event online. And one of the collaborative centers that has been agreed to come and then cheer together is the Collaborative Center of the WHO on TB Prevention from Brescia, and I have a pleasure to invite Professor Matteelli to do a welcome and then show an example on how he managed to support the WHO to deliver the best technical support to the countries. Over to you, Alberto.
Thank you very much. Thank you very much. Sorry, let me put it here. Andrei, and thanks to all here, and also for inviting me. It's really a pleasure and an honor to be here in this very important day. So actually my talk will be a little bit more on a technical topic rather than what Andrei was mentioning, on a technical topic which is prevention. And prevention, neglected area for a long time in TB, now is becoming a matter of growing importance. This was recognized for the first time in 2014, 2015, and was put into the WHO NTB strategy for the very first time. It took so many years to understand how prevention can be important for the fight of tuberculosis. You can see here under the D section that prevention is mentioned for the first time. And basically that came out from mathematical modeling done in previous years that were mentioning that what we can do to impact the TB epidemic is something by diagnosing and treating patients. That was the core up to that time, but you can do much more by identifying and treating also people with the infection. I'm the director of this collaborating center in Brescia. We were first, we entered the system in 2010. At that time, one of the major priority was tuberculosis and HIV co-infection. So we concentrated our activity, our intervention in that area. Then things changed over time. And one of the characteristics of the WHO Collaborating Center is that they adapt what is the priority for the WHO. And our last contract, the renovation is done every 4 years, so we had the time to demonstrate that we are capable of contributing to the WHO work. Our last renovation in 2022 was then on TB prevention. We are here today for basically clapping to the UCL that is becoming a new WHO collaborating center, and we at Brescia are particularly happy for that because there will be a lot of chances to work together in the fight with TB, and particularly in the area of prevention. The area of prevention is not doing very well. If we look at the impact by 2021, then we see that compared to the target set by the United Nations meeting in 2018, set by 2022, then first it's important to mention that those targets were I would say, very minimal. They were not that ambitious. And what we do, 42% of the target reached for people living with HIV, which is not the target of the UN, but is just the target of the total population of people living with HIV. About the true targets, only 40% of children were contacts and 3%, only 3% of adults were contacts. So not ambitious targets, not reaching those targets. This tells us that we have a big problem there. And this big problem asks for research. And this research should touch every single step of the cascade of prevention. So here is an important concept. As we can depict a cascade of care, we can also depict a cascade of prevention. And you can see here that the steps in these figures are many. So there are many, many areas where we can have problems and where we can impact and make a difference in this cascade of prevention. You can hear increasing the population that is target for this intervention, optimizing the recruitment process, definitely getting much better in diagnostics for TB infection. We know that we estimate almost 2 billion people who are positive at a latent test, but we have no idea how many of them actually harbor a vital mycobacteria. And the same is for regimens. We are down to 1 month regimens so far, but 1 month treatment regimens for people who have no signs or symptoms is already too much. And therefore, we have important research priorities in TB prevention. That's where we really expect that the UCL and the new WHO Collaborating Center, we can make really a difference and can make a step advance very much. One is on the definition of the pool of infected, those 1.8 billion, that are who are really candidates for TB treatment, which means basic research on persistency, diagnostic of latency, and diagnostic on the early reactivation stages or incipient TB, how is it called today. But at the same time, you can also strengthen all the other steps of the cascade of care by implementation research to expand target population, get to new treatment regimens, shaping the drug and enable the drug market and enable it, and then involve and sensitize communities. So there is really I'd say a very exciting panorama of the interventions and needs that can, should, and will be covered by the new collaboration center. Thank you very much for your attention.
Thank you so much, Alberto. So now we have the pleasure of inviting Susan Hopkins, Chief Medical Advisor, Clinical and Public Health Group, UKHSA.
Good morning, everyone. And as I get my microphone on, it's a huge pleasure for me to be here for two reasons. One is that while I'm here representing UK Health Security Agency, UCL is my academic home and the Royal Free was my clinical home. And I've worked for many years with Marc Lipman on looking at TB. So this feels like a bringing together of a number of different areas. Huge congratulations to UCL. This is an important achievement in the many milestones UCL have achieved in looking and managing TB over very many years. And it's the culmination of the collaboration efforts they do across many different sectors of the university, the society, the governments, and the world. And so it is those collaborations that are being recognized by this collaboration center. I have to say, when I was asked to talk about being a state actor, I didn't really know what that meant. And so I had to look it up. And it said that state actors are individuals or organizations that are part of government or the state apparatus and have the authority to make enforce laws, policies, and regulation. So I think I'm on the outskirts of being a state actor. My job is to advise and influence. The government and the ministers make the policies and the decisions. But it is those policies and decisions and the funding that are allocated to those that are really important in TB allocation. And us in UKHSA, working now with the UCL Collaboration Centre, will have four very important areas to look at. One is the clinical pathways to diagnostics, screening, TB, treatment for individuals who are affected. The second is the public health actions related to contact tracing, screening of individuals who've got latent TB, management of outbreaks, through both the detection of outbreaks through whole genome sequencing, refined over many years, and also the key components of surveillance, understanding and evaluating whether we're meeting our targets and why aren't we meeting those targets. And the final one that I would say is the advocacy and awareness for the groups that are overrepresented in TB infection. So I think we need to recognize that until we have equity of healthcare across the world and in this country for marginalized groups, we will not eliminate TB. So all of those four actions and those four areas are underpinned by research and innovation. And we won't be able to achieve elimination globally unless we have effective research and innovation in all of those spaces. So this collaborating centre will be central to that mission for WHO, but also for the UK. What about UKHSA? So we're a relatively new organisation, born in a pandemic, and our job and our mission is to prepare for and respond to health threats. Infectious diseases is at the core of our mission, and TB is one of our key ambitions and strategies to work towards elimination in the UK. We will work very closely and have worked very closely with UCL, both in previous days and previous typing methods such as VNTR, in looking at how we implement whole genome sequencing in practice, finding clusters, in investigating drug-resistant cases, and people will remember the Eyes and Eyes cluster. That was a very close collaboration between UCL and the partner hospitals in North London and its predecessor organisation, Public Health England. We're also very keen on innovation in ensuring that we have the best diagnostic services, the best whole genome sequencing services, and that we evaluate and understand the impact of our interventions across TB. From our point of view in moving forward, we are going to be working hard to support the UN high-level resolution and high-level meeting on tuberculosis. And we know that the key to decision makers' heart is evidence. The ability to show cost-effective interventions to eliminate TB what will make all the difference, not just in this country and globally. So thank you for the work that you do. Huge congratulations on achieving this amazing milestone, and I look forward to future collaboration.
And then, indeed, Stela, Lele will be talking about specifically what are the terms of references and the scope of work of the collaborative center that she is director of now.
So now we've all heard from our wonderful speakers, our strategic partners, emphasizing the importance of networks, of collaboration. We've heard about the breadth of what we do at UCL. We've heard even about the environment that our collaborating center will exist in, which is the Institute for Global Health. So my task here now is to take you through what we do, what we will do in collaboration with the WHO. But I thought it is key for me to start with outlining what we want to be known for. What are we about? We want to be known for doing high-quality, policy-informing research in the area of tuberculosis and TB-associated multimorbidity, and we will use interdisciplinary methods, beautifully outlined by Marc, and we will do this and work through the entire spectrum of tuberculosis infection, focusing on latent TB, focusing on early disease, TB disease, whether it's drug-sensitive or drug-resistant, looking at the sequelae of TB disease itself, post-TB lung, and very keen on expanding what we do to the comorbidity space. So we also want to be known for being enablers, facilitating those networks, people who are doing research in the areas that are priority to us and, of course, the WHO. And underlying what we do, underpinning it all, will be the principle of social justice. Ultimately, we want to do what we do to be able to impact people's lives and redress inequalities. I think the human right to science encapsulates it all, because it is about people benefiting from science and the right for them to also participate in science, and we will be guided by those principles. So we have very specific terms of reference for our work with the WHO, summarized in 2 objectives. The first objective will be about TB prevention, including scaling up of TB preventive treatment. So we would possibly also look at TB prevention from vaccines, but I think TPT will be the primary focus of our work with WHO Euro. We're also keen on capacity strengthening of programs, and we have very specific work areas that we will be focusing on. So obviously research, technical consultations, and of course training and education will be a key part of developing capacity. Specifically, we will conduct research that informs global policy development and hopefully facilitate global TB research and generate new evidence. Through technical consultations, we will work with countries to support them to scale up the various interventions upon, obviously, their invitations. And we will hopefully do lots of expert consultations with WHO Geneva and other parties who are keen to work with us in that way. For training and education, we will focus on developing the skills to do screening and diagnostic research within member countries and beyond. So for policy development work, we will be doing evidence synthesis, as we have been in the past years, to inform guideline development group deliberations. We will do early scoping reviews to support decisions to update a particular guideline on testing and treatment of TB infection. And we will implement research to scale up TB preventive treatment, including for contacts of people diagnosed with DRTB. For this, we will need to know the country situation, and we will conduct K-cascade analysis, such as what Alberto was talking about, to understand the local context. And we're also working closely with WHO Euro to develop an operational research protocol for evaluating TPT, TB preventive treatment, among DRTB contacts. This is something that will be done with colleagues at the MRC Clinical Trials Unit. Just as an example of the kind of work that we already do in the policy development space, just picking just a couple. So we did a landscape analysis to look at what is out there for tests for tuberculosis infection. And of course, not much is new, just, we're tinkering with variations of IGRA, and we bring more skin tests, but the skin test was interesting. So we went ahead and we did evidence synthesis to look at whether TB-specific skin tests can be used as an alternative to what we currently have, which is the PPD tuberculosis skin test, as well as used as an alternative to IGRA. So we were invited, we bid actually successfully for consultancy to look at this work for the WHO, and we looked at diagnostic performance of this new TB skin test. We looked at their safety profile. We looked at whether these would be tests that people want. We don't often ask that question. And we also looked at the health system's impact of using these new TB skin tests. So this work was finally incorporated into guidance, and that green module, which came out last year, outlines this new policy around the use of these new TB skin tests, and the work is already also published. So this is really good news. And I just received further good news just before this meeting started. Lynn Altes from NHS England just informed me that based on the work that we're doing in the UK, looking at this new TB skin test and also the work that we've done for the WHO, NHS England will be changing their guidelines to actually adopt the new TB skin test. Will include it, which is great, as an option alongside IGRA, which is perfect. Love it. So another sort of type of scoping review that we did was looking at whether the new mRNA transcriptomic signatures were mature enough for a sort of similar guideline development group process to happen. And that question is still outstanding because clearly they're not mature enough. So specifically for technical consultation, invited by countries, we will help them adapt the WHO recommendations according to their local context. So we've got several that are out there around TB screening, around TB prevention. And for expert consultation, what I'm talking about here is a role that we have to support the WHO to develop the agenda for global consultations on research and consultation. And I'll give you an example. So last year we convened a meeting that looked at innovative clinical trial designs for evaluating TB preventive treatment in future clinical trials. So discussing what the issues might be, and obviously a primary issue is that with effective treatment around, we are likely going to need like really big trials because we're really not going to see as many events perhaps when we're doing these trials, and we needed to think with some clever people in the room about the right methodology that we can then use if we are expecting small events in trials. That's just one of them, but we looked at how we are screening, whether endpoints could be measured differently, whether we should be looking at subclinical TB. So these are the sort of things that we can inform. For capacity development and strengthening, we want to run a screening and diagnostic research course, but it'll be more applied, using applied epidemiology methods. And I'll give you an example. We do a lot of individual patient data meta-analysis. Marc Lipman talked about a beautiful example that led to the development of the Periscope TB calculator. So that's a huge data set that's sitting somewhere. We also have another recent example where we looked at an individual patient data analysis to again understand the predictive value of interferon gamma release assays and the tuberculin skin test, and this time focusing more on the high burden settings, whereas the Periscope TB was more low incidence. So we needed to get a sense of whether we can use the data that we have, the IPD that we have, to develop a similar calculator for high burden settings. But the answer is sadly it's going to take a long time because the predictive ability of these tests is not so great in high burden settings where they are needed the most. So the idea is that we could get groups of people from NTPs, national TB programs, and other interested parties who are interested in learning these applied methods. So of course, having this platform, having this collaborative center also helps us further our own footprint and expand the work that we do around TB policy and research. An example would be this idea of exploring what we mean by TB disease, the area of early TB disease. And with that, there have already been consultations with the WHO, led by Hanif, and questioning whether the paradigm that we have been using suits us, does it suit where we're trying to get to? And the answer is perhaps no. But with concepts like these, we'll have to think about how do you diagnose early TB properly? Then, if you do pick it up, what do we give people for treatment and for how long? So these are the questions that then come out of this sort of work. Another way that we expand the impact that we have is around clinical trials, and there's some that are still coming down the pipe. So we heard about SHINE, we heard about CHAMP, we heard about SURE, and we heard about the ambitious Unite for TB. I wish there was a Unite for TB that looks at TB preventive treatment. Sometimes I think that what we have, that's it, which is kind of disheartening. And we do other collaborations. So CUT-TB is a collaboration with groups in South Africa to look at universal testing for TB among contacts. And RIT-TB is our very own baby here in the UK, where we're looking at the new TB skin tests to see whether they could be used within the NHS. And we're also going to be looking at the short regimens, rifapentine-based, 1HP, 3HP. So that's work that's coming, work that will likely impact local policy here, but also contribute to global policy. So we're also looking at innovation. We do a lot of systematic reviews, and if you've done one, you know that after doing just one, you never touch one again. So it is a great incentive to find ways of doing systematic reviews rapidly, of extracting data rapidly. And here at UCL, there's a team that is looking into that for extracting pharmacokinetic parameters from papers. Frank is not here today, but this is the work that he's leading. We're also doing other AI work, trying to improve how we read the tuberculin skin test, and hopefully we can come up with a really quick method that patients could use and evaluate their own indurations, whether they're positive, negative, so that they don't have to come back for that second visit, which is currently going to kill the new TB skin test. So if we don't get that right, that innovation right, then the implementation of the new TB skin test will be in jeopardy. Continuing the style of shameless plugs, Mark, I just want to plug another way that we want to increase our impact, which is through individual patient data. We are currently the holder or the curator of global individual patient data on tuberculosis right now for the WHO. We're collecting data on drug-resistant TB from observational studies as well from clinical trials. However, storing the data is not going to get the data analyzed. So plugging for people to get in touch, contribute data, request to use this data. Ultimately, we're able to honor the principle of open science and reuse this wonderful resource that we have. With that, I can say thank you and take questions, not many.
We have people looking and participating into this webinar, and as I mentioned, there are plenty on. We got about 200 registrants on it from about 50 countries, and only 30 countries out of those were from region. So this event has a global coverage, and your terms of reference of the collaborative center, not yours, but have been made publicly vocal. So please get ready to be hunted down by the countries requesting the technical support and so on. We've got perhaps the best constellation of the support that you as a new director of the collaborative center can get. Thank you very much indeed, colleagues. And then indeed a global coverage of the event itself. I did not have a chance to present myself. My name is Andrei Dadu. I'm an epidemiologist working in the regional office of WHO in Europe. The country number that we are covering on and serving on are 53, which is making the regional office the biggest office compared to other regions in terms of the number of the member states. Therefore, we have been having a privilege to have United Kingdom in our region, and therefore the opportunity and the privilege of having and facilitating the designation came to my plate, and I was going through that with such a pleasure. Thank you very much indeed. In addition to that, I do have a modest role and a high privilege indeed to identify, and has been highlighted already today, such a deep expertise, a large expertise and a deep experience that UCL and specifically the Institute of Global Health is capable of. And on behalf of Hans Kluge, our regional director, I have, again, a privilege to hand over a modest sign of such an expertise and the contribution that we're very much looking forward. I would like to highlight the fact that the designation of the Collaborative Center took place on the 24th of March 2023, and took a bit of time for us to make this event happening because of those agendas and having you on it as well. Nevertheless, the letter has been sent earlier, and this is just a replication of the letter with an engraved plate of the center, which is indeed a modest highlight of a large and deep expertise that the Collaborative Center have. Thank you very much indeed, Lele, and congratulations.
I remember seeing one of these visiting a WHO Collaborative Center on malaria.
A first one.
In Barcelona, and thinking, wow. Please, Ibrahim, I think we've reached the end of this wonderful event.
Excellent. So it's really great to be here and a privilege to close down the event. I get to say all the nice things and thank people. So as someone in global health, I kind of think it can get confusing with all the international acronyms and organizations that operate on in this space. We forget that actually the WHO is the only global health authority. So in a sense, we're kind of all WHO, and with or without a collaborating center, we have an obligation and a duty to contribute to the work of the WHO. So it's particularly a privilege and an honor that the WHO has sought fit to recognize our expertise and contribution by awarding this collaborating center to UCL. And I'm looking forward to what we would do with the center, building on the incredible work we've done to date. As Geraint indicated earlier on, there are 4 collaborating centers at UCL. Actually, 2 of them sit within our faculty in our Institute of Epidemiology and Healthcare, the one on Arts and Oral Health, and the third one was co-founded by one of our PIs in the Institute of Epidemiology, Maria Kett. So there's an opportunity for an internal conversation on how we maximize the presence of these centers. I say this because part of the privilege and opportunity of hosting these centers is something that Dr. Tedros said in conversations we were having with him within the context of the Global Preparedness Monitoring Board, where we were thinking about how do we consult the global academic community? What's the mechanism to get to all of the expertise and brains around the world to inform preparedness? And his response was, we should use the Collaborating Center Network. So we're seen very much as part of now a community that when there is going to be a global consultation or a global discussion that requires academic expertise, would have that privileged opportunity to be part of that conversation. And it's really great to be part of that. So I suppose what I'd like to move on to, given that we're at the end of the event, is to say a few thanks to numerous people. I'm really grateful to the people in the room, people online, globally, in the UK, people working in TB, in local authorities, and in public health departments. I did see a lot of names in the chat, as well as the 50, 80 odd countries around the world. that are part of this. It's great that you've been able to join us to celebrate this success and conversations about what we do in the future on TB control. I'm also grateful particularly to colleagues from WHO Europe, Andrei, Hans, and the leadership of the department, because I know how much work has gone into over the last 3 years with Lele to get us to this stage, the multiple paperwork and processes you had to go through. So it's really a pleasure to see you in the room today and to be celebrating the fact that we've reached this point. To colleagues in Geneva, we've worked, I feel quite old to say, for decades now on TB, and I think it's a pleasure to see as we go towards a high-level meeting in September, together with other academic communities across the world, that we use this opportunity of the Collaborating Center to ask of our leaders to prioritize TB, to move towards action, as opposed to how far we've got, which is great progress to date. But I think there's a distinct opportunity that if we organize ourselves collectively, we can actually do more, get the commitment to be more than it is in the current draft of the declaration, and get us to the stage where leaders commit to concrete action. And I'm looking forward to how we do that together using this Collaborating Center. To our closest partners, LSHTM, I'm really proud and pleased to see so many friends and colleagues here in the room. I think it shows the strength of our relationship that you are here in person. Okay, it's not really far, but actually, with this era of remote working, you could easily have sat at your desks and joined us online. But the fact that you're here in the room really makes me pleased and proud. And I hope that we'll use this Collaborating Center and see it as really our joint baby, and that we work together to input into its work and work with WHO. To UCL-TB and the community here, Neil, Mark, great work. We started this again with LSHTM many, many years ago, and I'm really pleased to see that it continues to be a very productive and collaborative conversation, and that we are now at the stage where we're able to celebrate this new entity as part of the UCL-TB community within the UCL Institute for Global Health. And I hope that the Collaborating Center will draw on that vast array of expertise across the institution using UCL-TB as the platform. I'm looking at team, the Center for Clinical Microbiology, of course, the other triad that created this entity. To the rest of the community, I say this is a moment for us to work together, to do the necessary research, to inform policy. But for me, listening to all of the breadth of work that UCL does and that I know many, many others do, the thing that I am struck by is how much of this is really all about impact and about reaching patients and communities. And I'd like to remind us that as we go forward in wherever we end up with this, that one thing we must do is to keep reminding ourselves that research, innovation, and all of that is not an end in itself. We have to work with community groups. TB Alert, and I can see that Paul is in the room, working with government and UKHSA to make sure that what we do is translated to policy in the country, but also through the WHO globally, so we can impact patients and lives. I'd like to finish with a particular thank to Lele. So I remember distinctly when we appointed Lele and Hanif, and the sort of vision I had was that there were quite a few of us working on TB, but that this would translate into a new generation of leadership that would reinvigorate our activity at UCL. I feel this event for me kind of proves that we're achieving that journey. Lele, I'm really proud of what you've done in terms of your research portfolio and your contributions to UCL. It also reminded me of a conversation that I had with Rob Wilkinson at about the time that you were appointed. And Rob says, Lele would do what Lele wants to do, but usually that's really good stuff. And I think it is good stuff. I am superbly pleased that you are with us and that you're leading this program of work. And I look forward to your directorship and leadership. Thank you.